At any moment, anywhere, an accident can happen. For many of us, that means simply keeping a watchful eye. However, patients taking an anticoagulant for atrial fibrillation face a unique challenge. But what if emergency surgery was less of a concern because an anticoagulant could be immediately reversed? We can't predict what tomorrow will bring, but we can set it in a brighter direction. Because the choice we make when choosing an anticoagulant today may help in an emergency situation in the future. Your foresight, their future.
Here, Ella, come on! Come say goodbye!
At any moment, anywhere, an accident can happen. For many of us, that means simply keeping a watchful eye. However, patients taking an anticoagulant for atrial fibrillation face a unique challenge. But what if emergency surgery was less of a concern because an anticoagulant could be immediately reversed? We can't predict what tomorrow will bring, but we can set it in a brighter direction. Because the choice we make when choosing an anticoagulant today may help in an emergency situation in the future. Your foresight, their future.
Here, Ella, come on! Come say goodbye!
At any moment, anywhere, an accident can happen. For many of us, that means simply keeping a watchful eye. However, patients taking an anticoagulant for atrial fibrillation face a unique challenge. But what if emergency surgery was less of a concern because an anticoagulant could be immediately reversed? We can't predict what tomorrow will bring, but we can set it in a brighter direction. Because the choice we make when choosing an anticoagulant today may help in an emergency situation in the future. Your foresight, their future.
Here, Ella, come on! Come say goodbye!
At any moment, anywhere, an accident can happen. For many of us, that means simply keeping a watchful eye. However, patients taking an anticoagulant for atrial fibrillation face a unique challenge. But what if emergency surgery was less of a concern because an anticoagulant could be immediately reversed? We can't predict what tomorrow will bring, but we can set it in a brighter direction. Because the choice we make when choosing an anticoagulant today may help in an emergency situation in the future. Your foresight, their future.
You're Ella, come on! Come say goodbye!
At any moment, anywhere, an accident can happen. For many of us, that means simply keeping a watchful eye. However, patients taking an anticoagulant for atrial fibrillation face a unique challenge. But what if emergency surgery was less of a concern because an anticoagulant could be immediately reversed? We can't predict what tomorrow will bring, but we can set it in a brighter direction. Because the choice we make when choosing an anticoagulant today may help in an emergency situation in the future. Your foresight, their future.
Here, Ella, come on! Come say goodbye!
At any moment, anywhere, an accident can happen. For many of us, that means simply keeping a watchful eye. However, patients taking an anticoagulant for atrial fibrillation face a unique challenge. But what if emergency surgery was less of a concern because an anticoagulant could be immediately reversed? We can't predict what tomorrow will bring, but we can set it in a brighter direction. Because the choice we make when choosing an anticoagulant today may help in an emergency situation in the future. Your foresight, their future.
Here, Ella, come on! Come say goodbye!
Boehringer Ingelheim đã đổi mới và phát triển không ngừng trong suốt 130 năm qua. Nhưng tất cả đã thực sự bắt đầu như thế nào? Vào ngày 30 tháng 7 năm 1885, Albert Boehringer mua một nhà máy sản xuất cao răng nhỏ ở Ingelheim, Tây Nam nước Đức. Vài năm sau, ông đã có một phát hiện đột phá. Nhờ tinh thần đổi mới của mình, ông đã tìm ra cách sản xuất axit lactic với thể tích phù hợp trong công nghiệp bằng cách sử dụng công nghệ sinh học, từ đó tạo ra sự thay đổi lâu dài cho thị trường. Ngay sau đó, Albert Boehringer phát triển một lĩnh vực kinh doanh tiên phong khác. Công ty của ông chiết xuất alkaloid để cung cấp cho các hiệu thuốc và ngành công nghiệp dược phẩm mới chớm nở. Dựa trên các hoạt chất có nguồn gốc từ thực vật này, Albert Boehringer đưa loại thuốc đầu tiên của riêng mình ra thị trường, đặt nền móng cho hoạt động kinh doanh dược phẩm cốt lõi sau này. Hoạt động kinh doanh dược phẩm tiếp tục tăng trưởng trong 2 thập kỷ tiếp theo. Thuốc mới trong các lĩnh vực điều trị khác nhau liên tục được đưa ra thị trường, và các cơ sở kinh doanh mới được xây dựng, bao gồm cơ sở Biberach ở Đức. Ngày nay vẫn là cơ sở nghiên cứu lớn nhất của công ty trên toàn thế giới. Từ năm 1948, Boehringer Ingelheim bước vào lãnh thổ mới và thành lập công ty con đầu tiên bên ngoài nước Đức. Ngày càng có nhiều công ty con ngoài nước Đức được thành lập. Công ty có khoảng 50.000 nhân viên trên toàn thế giới vào năm 2017. Trong những năm 1970, Boehringer Ingelheim mở rộng sang thị trường Hoa Kỳ và thiết lập một lĩnh vực hoạt động mới, thuốc thú y. Công nghệ sinh học cũng được mở rộng hơn nữa, và loại thuốc được sản xuất bằng công nghệ sinh học đầu tiên của công ty để điều trị nhồi máu cơ tim cấp tính đã được phê duyệt. Công ty ngày càng có nhiều thành tựu hơn. Ví dụ như, việc lây truyền HIV từ mẹ sang con có thể ngăn chặn được. Một loại thuốc điều trị bệnh phổi gây suy nhược, COPD, được đưa ra thị trường. Lần đầu tiên sau 50 năm, thuốc chống đông máu với một phương thức hoạt động hoàn toàn mới có thể được đưa ra thị trường. Boehringer Ingelheim thành công trong việc nghiên cứu bệnh tiểu đường và đạt được thành công điều trị xuất sắc. Năm 2016, ngành thú y được củng cố đáng kể thông qua việc hoán đổi lĩnh vực kinh doanh với Sanofi. Boehringer Ingelheim trở thành một trong những công ty dẫn đầu thị trường về thú y trên thế giới. Và thành công sẽ tiếp tục. Công ty do gia đình sở hữu trong tương lai sẽ hợp tác chặt chẽ hơn nữa với các công ty khởi nghiệp và trường đại học để hỗ trợ nghiên cứu của họ với các nghiên cứu phát triển, bí quyết và nghiên cứu lâm sàng. Câu chuyện của Boehringer Ingelheim là một ví dụ kinh điển về những đổi mới thực sự, và sẽ còn tiếp tục đổi mới không ngừng.
At any moment, anywhere, an accident can happen. For many of us, that means simply keeping a watchful eye. However, patients taking an anticoagulant for atrial fibrillation face a unique challenge. But what if emergency surgery was less of a concern because an anticoagulant could be immediately reversed? We can't predict what tomorrow will bring, but we can set it in a brighter direction. Because the choice we make when choosing an anticoagulant today may help in an emergency situation in the future. Your foresight, their future.
You're Ella, come on! Come say goodbye!
Randomized controlled trials, or RCTs, generate high-quality evidence for drug approval. However, the highly controlled conditions can limit how applicable the findings are to routine practice. Well-designed real-world studies can add to RCT data. By assessing broader patient populations, alternative drug comparators, and different outcomes in different clinical settings. Together, multiple real-world studies may reassure physicians about the safety and efficacy of a particular drug, thereby supporting clinical decision-making. Dabigatran has been tested extensively in thromboembolic diseases in the Revolution clinical trial program. The pivotal study, RELY, established the favorable efficacy and safety profile of 2 dabigatran doses for stroke prevention in patients with AF versus well-controlled warfarin. RELIABLE, an extension study of RELY, showed consistent results for dabigatran up to 6.7 years of follow-up. RCT data from patients with AF undergoing cardiac interventions or following PCI also reinforced the positive safety profile of dabigatran at doses approved for stroke prevention in AF. In RE-Circuit, uninterrupted dabigatran was associated with significantly fewer major bleeding events versus warfarin in patients undergoing catheter ablation of AF. In RE-Dual PCI, 2 dual antithrombotic regimens with dabigatran significantly reduced the rate of major and clinically relevant bleeding after PCI versus warfarin triple therapy with non-inferior efficacy. These differences were maintained after acetyl salicylic acid was stopped at 1 or 3 months in the warfarin group. Overall, RCT data consistently demonstrate the positive safety profile of dabigatran in multiple indications. Findings from RCTs are strengthened by real-world evidence. The safety of dabigatran has been evaluated in numerous retrospective or database analyses by independent researchers and health authorities, including the FDA, against different OACs in different regions of the world. Real-world evidence has shown that, in terms of major bleeding, dabigatran is similar or better than warfarin, better than rivaroxaban, and similar to apixaban. Prospective real-world data from the Gloria AF registry showed low stroke and bleeding rates of dabigatran over 2 years of follow-up. Together, the data from RCTs and real-world practice consistently show the favorable safety profile of dabigatran. Randomized controlled trials, or RCTs, are considered the gold standard of evidence-based medicine. Multiple rigorous RCTs provide a strong foundation for the characteristics of dabigatran in multiple cardiology settings. The RELY trial and the extension study, RELIABLE, established the favorable safety and efficacy of 2 dabigatran doses for stroke prevention in patients with AF compared with well-controlled warfarin with up to 6.7 years of follow-up. More recent RCT data from patients with AF undergoing ablation or following PCI reinforce dabigatran's positive safety profile. The REVOLUTION clinical trial program of dabigatran in multiple cardiology settings provides a firm foundation that has been built on by real-world studies. The safety profile of dabigatran has been evaluated in real-world studies in broad patient populations against different comparators in different regions of the world and by various sponsors, health authorities, and independent research institutions. These studies have expanded our knowledge of the characteristics of individual NOACs, as no RCT has compared the different NOACs directly. Rigorous real-world analyses have consistently demonstrated dabigatran's safety profile relative to VKAs. Real-world studies also suggest that the safety profile of dabigatran is better than rivaroxaban in terms of major bleeding. One important analysis of more than 118,000 Medicare patients conducted by the US FDA and the Centers for Medicare and Medicaid Services showed that the rates of major extracranial, intracranial, and gastrointestinal bleeding were significantly reduced with dabigatran versus rivaroxaban. While fewer real-world studies are available for apixaban, the results suggest that dabigatran's overall safety profile is similar to apixaban's. In addition, prospectively collected real-world data from nearly 5,000 dabigatran patients in GLORIA AF showed low stroke and bleeding rates and supported the sustained safety profile and effectiveness of dabigatran over 2 years of follow-up. So, what makes the dabigatran data stand out versus other oral anticoagulants? Dabigatran is the only NOAC with a strong evidence base from RCTs, plus the most comprehensive set of real-world data of any NOAC. Numerous studies from various sources have strengthened the safety profile of dabigatran versus VKAs and other NOACs. Together, these data reassure physicians about the safety and efficacy of dabigatran, thereby supporting clinical decision-making.
Boehringer Ingelheim đã đổi mới và phát triển không ngừng trong suốt 130 năm qua. Nhưng tất cả đã thực sự bắt đầu như thế nào? Vào ngày 30 tháng 7 năm 1885, Albert Boehringer mua một nhà máy sản xuất cao răng nhỏ ở Ingelheim, Tây Nam nước Đức. Vài năm sau, ông đã có một phát hiện đột phá. Nhờ tinh thần đổi mới của mình, ông đã tìm ra cách sản xuất axit lactic với thể tích phù hợp trong công nghiệp bằng cách sử dụng công nghệ sinh học, từ đó tạo ra sự thay đổi lâu dài cho thị trường. Ngay sau đó, Albert Boehringer phát triển một lĩnh vực kinh doanh tiên phong khác. Công ty của ông chiết xuất alkaloid để cung cấp cho các hiệu thuốc và ngành công nghiệp dược phẩm mới chớm nở. Dựa trên các hoạt chất có nguồn gốc từ thực vật này, Albert Boehringer đưa loại thuốc đầu tiên của riêng mình ra thị trường, đặt nền móng cho hoạt động kinh doanh dược phẩm cốt lõi sau này. Hoạt động kinh doanh dược phẩm tiếp tục tăng trưởng trong 2 thập kỷ tiếp theo. Thuốc mới trong các lĩnh vực điều trị khác nhau liên tục được đưa ra thị trường. và các cơ sở kinh doanh mới được xây dựng, bao gồm cơ sở Biberach ở Đức. Ngày nay vẫn là cơ sở nghiên cứu lớn nhất của công ty trên toàn thế giới. Từ năm 1948, Boehringer Ingelheim bước vào lãnh thổ mới và thành lập công ty con đầu tiên bên ngoài nước Đức. Ngày càng có nhiều công ty con ngoài nước Đức được thành lập. Công ty có khoảng 50.000 nhân viên trên toàn thế giới vào năm 2017. Trong những năm 1970, Boehringer Ingelheim mở rộng sang thị trường Hoa Kỳ và thiết lập một lĩnh vực hoạt động mới, thuốc thú y. Công nghệ sinh học cũng được mở rộng hơn nữa, và loại thuốc được sản xuất bằng công nghệ sinh học đầu tiên của công ty để điều trị nhồi máu cơ tim cấp tính đã được phê duyệt. Công ty ngày càng có nhiều thành tựu hơn. Ví dụ như, việc lây truyền HIV từ mẹ sang con có thể ngăn chặn được. Một loại thuốc điều trị bệnh phổi gây suy nhược, COPD được đưa ra thị trường. Lần đầu tiên sau 50 năm, thuốc chống đông máu với một phương thức hoạt động hoàn toàn mới có thể được đưa ra thị trường. Boehringer Ingelheim thành công trong việc nghiên cứu bệnh tiểu đường và đạt được thành công điều trị xuất sắc. Năm 2016, ngành thú y được củng cố đáng kể thông qua việc hoán đổi lĩnh vực kinh doanh với Sanofi. Boehringer Ingelheim trở thành một trong những công ty dẫn đầu thị trường về thú y trên thế giới. Và thành công sẽ tiếp tục. Công ty do gia đình sở hữu trong tương lai sẽ hợp tác chặt chẽ hơn nữa với các công ty khởi nghiệp và trường đại học để hỗ trợ nghiên cứu của họ với các nghiên cứu phát triển, bí quyết và nghiên cứu lâm sàng. Câu chuyện của Boehringer Ingelheim là một ví dụ kinh điển về những đổi mới thực sự và sẽ còn tiếp tục đổi mới không ngừng. Boehringer Ingelheim đã đổi mới và phát triển không ngừng trong suốt 130 năm qua. Nhưng tất cả đã thực sự bắt đầu như thế nào? Vào ngày 30 tháng 7 năm 1885, Albert Boehringer mua một nhà máy sản xuất cao răng nhỏ ở Ingelheim, Tây Nam nước Đức. Vài năm sau, ông đã có một phát hiện đột phá. Nhờ tinh thần đổi mới của mình, ông đã tìm ra cách sản xuất axit lactic với thể tích phù hợp trong công nghiệp bằng cách sử dụng công nghệ sinh học, từ đó tạo ra sự thay đổi lâu dài cho thị trường. Ngay sau đó, Albert Boehringer phát triển một lĩnh vực kinh doanh tiên phong khác. Công ty của ông chiết xuất alkaloid để cung cấp cho các hiệu thuốc và ngành công nghiệp dược phẩm mới chớm nở. Dựa trên các hoạt chất có nguồn gốc từ thực vật này, Albert Boehringer đưa loại thuốc đầu tiên của riêng mình ra thị trường, đặt nền móng cho hoạt động kinh doanh dược phẩm cốt lõi sau này. Hoạt động kinh doanh dược phẩm tiếp tục tăng trưởng trong 2 thập kỷ tiếp theo. Thuốc mới trong các lĩnh vực điều trị khác nhau liên tục được đưa ra thị trường, và các cơ sở kinh doanh mới được xây dựng, bao gồm cơ sở Biberach ở Đức. Ngày nay vẫn là cơ sở nghiên cứu lớn nhất của công ty trên toàn thế giới. Từ năm 1948, Boehringer Ingelheim bước vào lãnh thổ mới và thành lập công ty con đầu tiên bên ngoài nước Đức. Ngày càng có nhiều công ty con ngoài nước Đức được thành lập. Công ty có khoảng 50.000 nhân viên trên toàn thế giới vào năm 2017. Trong những năm 1970, Boehringer Ingelheim mở rộng sang thị trường Hoa Kỳ và thiết lập một lĩnh vực hoạt động mới, thuốc thú y. Công nghệ sinh học cũng được mở rộng hơn nữa, và loại thuốc được sản xuất bằng công nghệ sinh học đầu tiên của công ty để điều trị nhồi máu cơ tim cấp tính đã được phê duyệt. Công ty ngày càng có nhiều thành tựu hơn. Ví dụ như, việc lây truyền HIV từ mẹ sang con có thể ngăn chặn được. Một loại thuốc điều trị bệnh phổi gây suy nhược, COPD được đưa ra thị trường. Lần đầu tiên sau 50 năm, thuốc chống đông máu với một phương thức hoạt động hoàn toàn mới có thể được đưa ra thị trường. Boehringer Ingelheim thành công trong việc nghiên cứu bệnh tiểu đường và đạt được thành công điều trị xuất sắc. Năm 2016, ngành thú y được củng cố đáng kể thông qua việc hoán đổi lĩnh vực kinh doanh với Sanofi. Boehringer Ingelheim trở thành một trong những công ty dẫn đầu thị trường về thú y trên thế giới. Và thành công sẽ tiếp tục. Công ty do gia đình sở hữu trong tương lai sẽ hợp tác chặt chẽ hơn nữa với các công ty khởi nghiệp và trường đại học để hỗ trợ nghiên cứu của họ với các nghiên cứu phát triển, bí quyết và nghiên cứu lâm sàng. Câu chuyện của Boehringer Ingelheim là một ví dụ kinh điển về những đổi mới thực sự và sẽ còn tiếp tục đổi mới không ngừng.
At any moment, anywhere, an accident can happen. For many of us, that means simply keeping a watchful eye. However, patients taking an anticoagulant for atrial fibrillation face a unique challenge. But what if emergency surgery was less of a concern because an anticoagulant could be immediately reversed? We can't predict what tomorrow will bring, but we can set it in a brighter direction. Because the choice we make when choosing an anticoagulant today may help in an emergency situation in the future. Your foresight, their future.
You're Ella, come on! Come say goodbye!
Randomized controlled trials, or RCTs, generate high-quality evidence for drug approval. However, the highly controlled conditions can limit how applicable the findings are to routine practice. Well-designed real-world studies can add to RCT data. By assessing broader patient populations, alternative drug comparators, and different outcomes in different clinical settings. Together, multiple real-world studies may reassure physicians about the safety and efficacy of a particular drug, thereby supporting clinical decision-making. Dabigatran has been tested extensively in thromboembolic diseases in the Revolution clinical trial program. The pivotal study, RELY, established the favorable efficacy and safety profile of 2 dabigatran doses for stroke prevention in patients with AF versus well-controlled warfarin. Reliable, an extension study of RELY, showed consistent results for dabigatran up to 6.7 years of follow-up. RCT data from patients with AF undergoing cardiac interventions or following PCI also reinforced the positive safety profile of dabigatran at doses approved for stroke prevention in AF. In RE-Circuit, uninterrupted dabigatran was associated with significantly fewer major bleeding events versus warfarin in patients undergoing catheter ablation of AF. In redual PCI,
in just a few minutes, the scientific symposia, Dabigatran, 10-year journey to protect AF patients, confidence in treatment, reversal agent readiness, will starting soon. We'd like to invite all of you to proceed into the ballroom and be seated. Please kindly turn your mobilization into silent mode. Thank you.
In the warfarin group. Overall, RCT data consistently demonstrate the positive safety profile of dabigatran in multiple indications. Findings from RCTs are strengthened by real-world evidence. The safety of dabigatran has been evaluated in numerous retrospective or database analyses by independent researchers and health authorities, including the FDA, against different OACs in different regions of the world. Real-world evidence has shown that, in terms of major bleeding, dabigatran is similar or better than warfarin, better than rivaroxaban, and similar to apixaban. Prospective real-world data from the Gloria AF registry showed low stroke and bleeding rates of dabigatran over 2 years of follow-up. Together, the data from RCTs and real-world practice consistently show the favorable safety profile of dabigatran. Randomized controlled trials, or RCTs, are considered the gold standard of evidence-based medicine. Multiple rigorous RCTs provide a strong foundation for the characteristics of dabigatran in multiple cardiology settings. The RELY trial and the extension study, Reliable, established the favorable safety and efficacy of 2 dabigatran doses for stroke prevention in patients with AF, compared with well-controlled warfarin with up to 6.7 years of follow-up. More recent RCT data from patients with AF undergoing ablation or following PCI reinforce dabigatran's positive safety profile. The Revolution clinical trial program of dabigatran in multiple cardiology settings provides a firm foundation that has been built on by real-world studies. The safety profile of dabigatran has been evaluated in real-world studies in broad patient populations against different comparators in different regions of the world and by various sponsors, health authorities, and independent research institutions. These studies have expanded our knowledge of the characteristics of individual NOACs. as no RCT has compared the different NOACs directly. Rigorous real-world analyses have consistently demonstrated dabigatran's safety profile relative to VKAs. Real-world studies also suggest that the safety profile of dabigatran is better than rivaroxaban in terms of major bleeding. One important analysis of more than 118,000 Medicare patients conducted by the US FDA and the Centers for Medicare and Medicaid Services showed that the rates of major extracranial, intracranial, and gastrointestinal bleeding were significantly reduced with dabigatran.
Gentlemen, in just a few minutes, the scientific symposium, Dabigatran, 10-year journey to protect AF patients, confidence in treatment, reversal, agent readiness, will officially start. We'd like to invite all of you to gather in the ballroom. Be seated and please keep your phones on silent mode. Thank you.
Showed low stroke and bleeding rates and supported the sustained safety profile and effectiveness of dabigatran over 2 years of follow-up. So, what makes the dabigatran data stand out versus other oral anticoagulants? Dabigatran is the only NOAC with a strong evidence base from RCTs, plus the most comprehensive set of real-world data of any NOAC. Numerous studies from various sources have strengthened the safety profile of dabigatran versus VKAs and other NOACs. Together, these data reassure physicians about the safety and efficacy of dabigatran, thereby supporting clinical decision-making.
Ladies and gentlemen, in just a few minutes, the scientific symposium, Dabigatran, 10-year journey to protect AF patients, confidence in treatment, reversal agent readiness is starting. We'd like to invite all of you to proceed into the ballroom and be seated. Please kindly turn your mobile phones into silent mode. Thank you.
Ladies and gentlemen, right after this, the
Ladies and
program.
gentlemen, the scientific symposium, Dabigatran, 10-year journey to protect AF patients, confidence in treatment, reversal agent readiness would like to begin. Professor Dr. Phạm Mạnh Hùng, Director of the Vietnam Heart Institute, Vice President of the Vietnam Cardiology Association. Xin được Associate Professor John Vincent Amerina, Clinical Associate Professor, Deakin University, Consulting Cardiologist, Geelong Cardiology Practice, Australia. Sir Stefan Holoza, Emeritus Professor of Cardiology, J.W. Goethe University, Germany. Master Dr. Nguyễn Tuấn Hải, Head of Department C6 of Vietnam Heart Institute, Lecturer of Cardiology at Hanoi Medical University. Nguyễn Ngọc Thủy, Head of Marketing of Boehringer Ingelheim, Vietnam. We'd like to invite on stage Ms. Nguyễn Ngọc Thủy, Head of Marketing of Boehringer Ingelheim, Vietnam, to have the welcome speech, please.
Ladies and gentlemen, professors, doctors, first of all, on behalf of Boehringer Ingelheim, Vietnam, I would like to thank Professor Dr. Phạm Mạnh Hùng, Professor John Vincent Amarino, Professor John Holoza, Dr. Hai, and in particular, doctors who are attending in this auditorium, as well as other participants who are online. After this, I would like to say a few words about Boehringer Ingelheim. Boehringer Ingelheim was formed in 1885 in Germany, focusing on innovative products. Currently, the company is present in more than 180 countries. With a 35 years presence in Vietnam, Boehringer in Vietnam has launched the leading products in diabetes, cardiology, rheumatology, interstitial lung disease, hematology, coagulation. Pradaxa appearing in Vietnam in 2012, and then 2019, Idarucizumab. We would like to thank you all for walking with us in this 10-year journey, and I'm sure that the journeys will continue. To conclude my opening speech, I would like to wish all of you good health, success, and continue to be a trusted partner with Boehringer Ingelheim Vietnam for protecting Vietnamese patients, empowered to protect for AF patients. Thank you all, and a big success to our meeting today. And now I would like to call upon Professor Phạm Mạnh Hùng, Director of Vietnamese Cardiology Institute, to
Gentlemen,
deliver
please
the
join me
welcome
in
remarks.
welcoming on stage Associate Professor Dr. Phạm Mạnh Hùng, Director of the Vietnam Heart Institute, Vice President of the Vietnam Cardiology Association, to share a few words. Please.
Many thanks for the kind introduction of the MC. Ladies and gentlemen, distinguished guests attending the meeting today, on-site, and those who are participating off-site. We know that for the past 3 years, COVID-19 has changed so many things, and today is one of the few meetings that we can see each other face to face, and then we can organize a meeting. However, the pandemic has given us an opportunity to develop and to take advantage of technology and technique to help everybody who are not capable of meeting on site, like coming here, then you can still follow the program and exchange opinions. And over the course of the past 2 years, Vietnam Association of Cardiology has been trying to deliver virtual program. However, if we can see each other face to face, then it would be great, because besides professional exchange, it is also a social interaction. Ladies and gentlemen, 10 years with an agent, NOAC or DOAC in Vietnam, the bigger trend is a journey, not too long, but not too short. And for the past 10 years, there have been a lot of clinical trial and clinical experience and how to use NOAC in clinical reality. Atrial fibrillation has become a concern for medical doctors and also surgeons, especially because of the aging population. Besides the conventional therapy, these days we have a lot more techniques such as ablation to switch AF back into sinus rhythm. And in clinical practice, we want to know that in those people who need a PCI AF patients who need ablations, when we use NOAC, is there anything different? And as far as we know, in Vietnam, there are 4 NOAC available in the market. How to use them? and are on the NOACs the same. Each of the agents may have a certain characteristic and how to apply it. And another important point is that when you use it, especially NOAC, for those with atrial fibrillation, and accidentally patient suffer an accident and need a invasive emergency urgency operation, we need to carry out surgical operation. And it may be hindered because of hemorrhage or bleeding. And the fact that we have a reversal antigen, specific antidote to neutralize the agent, carrying out the surgical operation, and then coming back to use the anticoagulant, which is so ideal in clinical reality. And with that, we can give patient another chance of survival. In today's meeting, it is our great pleasure to welcome and to listen to the experts in the world and also elsewhere. How to use NOAC in general and dabigatran in particular. I'm sure, I do hope that today's meeting should be very useful. We also hope that should you have any questions, you can raise a question and send to the speaker and the panelists so that we can raise the inquiries, exchange clinical experience, and do a better job. Once again, I would like to thank Boehringer Ingelheim for being the trusted partner with Vietnam cardiology in the whole time of the pandemic. And in order to provide continuing education for healthcare providers to access the most up-to-date. And I also would like to thank everybody who are here today. And now, without further ado, the first speaker, Professor John Vincent, John Amerina, cardiologist from Geelong Hospital in Australia, with the topic on NOACs, the same clinical experience.
Please join me in welcoming Associate Professor John Vincent Marina, Clinical Associate Professor, Deakin University, Consulting Cardiologist, Geelong Cardiology Practice, Australia, with the first presentation. Are all NOACs the same? Insights from Clinical Practice to RWE. Thưa quý vị,
Dr. Amerina, you can share your slide.
Okay, well, Thank you very much for asking me to give this presentation today to discuss the use of NOACs in our contemporary society, and particularly with a focus on dabigatran and the results of the RELY study, which really revolutionized the management of patients with atrial fibrillation with respect to stroke prevention. My disclosures are here. I've been lucky enough over the years to work with the companies that have produced the NOACs at both a steering committee level for several of the studies as a clinical investigator. So just to start, when we see patients with atrial fibrillation, we have to assess their risk of stroke. And initially we did this with the CHADS score, but in more recent times, the CHADS-VAS score has been the more accurate way of assessing the stroke risk in patients with AF. It's really very helpful in identifying the truly low-risk patient and is a better discriminator of risk between in patients with AF than the CHADS score. Now, the European Society of Cardiology's management structure for AF is outlined here, and they've suggested this pathway, the ABC pathway, that we won't need to go to in detail, but basically the first component is A, is anticoagulation to avoid stroke and to identify which patients will benefit from anticoagulation and which patients won't. B is better symptom control. You look at the patient's quality of life, optimize rate control, consider a rhythm control strategy to really make patients feel as well as they can. And then C is extremely important. That's managing comorbidities. So lifestyle changes, alcohol intake, losing weight, exercise, diet, etc. And that's a really coordinated approach to really manage all the aspects of our patients who have atrial fibrillation. So just another way of looking at that in a little more detail. So step one is that you look at patients and identify which patients need anticoagulation. So the truly low-risk patient has a CHADS-VAS score of 0 for males and 1 for females, and no therapy is required for them. Then you look at the patients, step two, the patients who have a CHADS-VAS 1 or more for males or 2 or more for females. You should really strongly consider anticoagulation, but you have to take into account the risk of bleeding, and we recommend doing a HAS-BLED score to do that, and that's really to identify modifiable risk factors for bleeding that we can change and reduce bleeding risk. The upshot of it all is, even if the patient has a high bleeding risk, this should not be used as a reason to withhold anticoagulation, because the net clinical benefit is clearly in favor of anticoagulation, even if the bleeding risk is high. And the way I like to put it to patients is that if you have a bleeding event, it's no good. It may require transfusion or even surgery, but most of the time you'll make a complete recovery with no long-term disability. On the other hand, if you have a stroke, you may have be completely disabled, you have trouble speaking, you may not be able to walk, you may need institutionalization. So the consequences of a stroke are much greater than the consequences of bleeding. And most patients, if you put it in those terms, will opt to have anticoagulation and say, yes, I'd like to reduce my risk of stroke, but accept a small risk of bleeding. And then the step three is to basically begin treatment. And in this era, NOACs are generally considered to be the best therapy and first-line therapy for reduction of stroke in patients with non-valvular atrial fibrillation. And we'll go into that in a minute. Warfarin was the standard therapy for many years, and it's a very good drug, as you can see from the data here. It really reduces the risk of stroke by about 64% compared to placebo. And basically, it's a really effective therapy, but it has several limitations because it has an unpredictable response, narrow therapeutic window. You need to monitor with blood tests on a regular basis, a slow onset and offset of action, frequent dose adjustments, numerous food and drug interactions, numerous drug and drug interactions, and some people are resistant. So it's good, it works, but it's difficult to manage in clinical practice. The whole landscape changed with the publication of the RELY study in 2009. And this, for the first time, looked at an agent against warfarin to prevent stroke in patients with AF. So in this study, dabigatran was used, and it really changed the whole landscape of management in this area. It was followed soon after by the factor Xa inhibitor study, so Rocket AF with rivaroxaban, Aristotle study with apixaban, and there were some similarities and some differences between these studies. So RELY was used the direct thrombin inhibitor dabigatran. The other two studies were the factor Xa inhibitors. The difference with RELY is at a probe design, so prospective, randomized, open label, blinded endpoints, whereas the other two were double blind, which were much more challenging from a clinical trial perspective. RELY and Aristotle, the CHADS score was 2.1, and these studies were done before the advent of CHADS VASC, which we use now, whereas in Rocket AF, they were a higher risk population with a CHADS of 3.5. The bleeding, the endpoints were pretty much the same. The bleeding endpoints were a little bit different, but not significantly. So concentrating on RELY, and this is the first study that was published in this domain, basically warfarin in red, 110 BD in blue, and 150 BD in green. You can see that the 150 milligram dose had a significant and highly statistically significant reduction in the endpoint of stroke and systemic embolism compared with warfarin, whereas the 110 dose was very similar to warfarin in its ability to prevent stroke and embolism. When you look at bleeding, you saw the opposite pattern. The 110 dose had significantly less bleeding than with warfarin, whereas the 150 milligram dose had similar bleeding to warfarin. And when you look at the components of the bleeding, major bleeding was reduced with both doses compared with warfarin. Life-threatening bleeding reduced with both doses compared with warfarin. Non-life-threatening was pretty much the same, but there was an excess of gastrointestinal bleeding with the higher dose, and I'll explain the reasons for that a little later in the presentation. In terms of intracranial bleeding, both doses significantly reduced the risk of intracranial bleeding, and this was a somewhat unexpected finding, but it has been reproduced in the other studies, as I'll show you in a moment. But this is a huge advantage, particularly in Asian populations who seem to be more prone to intracranial hemorrhage than Caucasian counterparts. And so having an agent that reduces the intracranial hemorrhage by so much is really advantageous. So in summary, the 110 milligram dose versus warfarin, comparable rates of stroke and systemic embolism, and a significant reduction in bleeding, whereas the 150 milligram dose had a statistically significant reduction in stroke and embolism, and in particular in ischemic stroke as an independent endpoint, and comparable rates of bleeding. So how does that compare with the other studies that have followed? Well, this is not head-to-head data, but this is looking at the magnitude of reduction in the primary endpoints and bleeding endpoints between the studies. And you can see that the dabigatran 150 and apixaban had a reduction, significant reduction in the primary endpoint of stroke and systemic embolism, and whereas the rivaroxaban and the 110 dose of dabigatran was similar, the other doses were superior. In terms of bleeding, basically the 150 was similar to warfarin, rivaroxaban was similar to warfarin, the dabigatran 150 was less, and the apixaban 5BD was less bleeding than with warfarin. We saw, however, that the primary endpoint of ischemic stroke is an independent without systemic embolism. Dabigatran 150 was the only agent that reduced ischemic stroke compared with warfarin. 110 of dabigatran, rivaroxaban and apixaban similar rates of stroke compared with ischemic stroke, whereas dabigatran 150 was the only one that reduced it independently and statistically significantly. Intracranial bleeding, however, was really reduced with all the agents. So both doses of dabigatran, both doses of rivaroxaban, both doses of apixaban, and with edoxaban as well, that hasn't been studied as much, but is an alternative NOAC that's been available in some places, but not as widely used as the other agents. So at the end of the RELY study, they said we've got this group of patients who've benefited from anticoagulation, more so with dabigatran and warfarin. And they say, well, let's follow them up and see if the benefits that they were achieved in the big clinical trial, where they were highly supervised, were translated into clinical practice after the trial was completed. So basically, they said to patients, if you're on dabigatran in the study, and remember it was an open label, so we knew what therapy they were receiving, they were then invited to participate and given open label dabigatran for the next few years. And we looked at the end of an average of 6 years, 0.7 years of follow-up, and found that the rates of stroke with both doses of dabigatran were still very low compared with warfarin. So basically, the benefits we saw in the trials were translated into the real world, where patients were followed less frequently and were basically not in a clinical trial environment. When we looked at bleeding, you saw, not unexpectedly, there was more bleeding with the 150 dose than with the 110 dose, but again, low levels of bleeding that were quite acceptable over a 6.7 year period. When we looked at intracranial hemorrhage or hemorrhagic stroke, basically you saw that there was a very low risk of intracranial hemorrhage with these agents, far lower than you'd expect to see with warfarin. So what it really means is that after the study was completed, patients continued on therapy, and the results we saw in the clinical trials were translated into what was seen in clinical practice in the real world. So just to look at a couple of groups of interest that we have to deal with in our clinical practice on a regular basis. So I'll cover the area of renal impairment, the elderly and obesity, because these are the patients that we commonly see coming through our doors that we need to treat with AF. So there are some differences between the NOACs with respect to renal excretion. Dabigatran is highly dependent on renal excretion, so 85% is excreted in the urine, whereas apixaban and rivaroxaban are far less dependent on renal function for excretion. And as you would expect, the half-life of dabigatran increases fairly significantly as the creatinine clearance diminishes. It does with the others as well, but not to the same extent. So let's have a look at RELY and see what the effect of renal function was on the efficacy and safety of dabigatran versus warfarin at both doses. So I'd like you to concentrate on the lower panels in this slide with the red, which looks at the differences in renal function over time. So normal renal function, mildly impaired, and more significantly impaired. And you can see for the primary endpoint of stroke and systemic embolism, the 110 dose here, 150 dose here, wasn't affected much at all by the change in renal function. So the benefits were just as great in the patients who had normal and impaired renal function. When we look at hemorrhagic stroke, we see exactly the same pattern, that renal function did not significantly impact the benefits of dabigatran over warfarin with respect to a reduction in hemorrhagic stroke. And when we look at bleeding, we see that as the renal function declines, the advantage of bleeding over warfarin diminishes. It's still equal to, but not as great as the normal renal function, and that's because of their dependence on renal excretion. On the other hand, we see that with the dabigatran 150 dose, diminishing renal function didn't really have any impact on increasing bleeding, which is a bit unusual, but it certainly was borne out in the clinical trial. We have some other data from a paper that was published by Stuart Connolly and a few others looking at the major bleeding in patients who had moderate degrees of renal impairment. And I'll point out to you, all these studies, the cutoff for creatinine clearance was 30. So there weren't any patients in these big studies that had a creatinine of less than 30 for creatinine clearance. And if they dropped below, most of the time, certainly in RELY, they were discontinued from the study. And so you can see basically that as the patients with the impaired renal function, the bleeding was no greater than with warfarin. And in fact, in the patients who received apixaban, that was less. But that was really based on a very low number of patients who received the lower dose of apixaban and had moderate renal impairment. So really only 150 odd patients. So really it's pretty difficult to be confident about that bleeding, reduction in bleeding in renal dysfunction with the Aristotle study at the low dose. What do the advisors say? The EHRA, a European Heart Rhythm Association, says in the context of NOAC treatment, renal function should be estimated by the creatinine clearance using Cockcroft Gold. And that's really pretty important. Now, for most patients who have normal renal function and normal body weight, have normal body weight, the eGFR is a reasonable surrogate for the creatinine clearance. But in the extremes of body weight, so people who are obese, people who are really thin and low body weight, the creatinine clearance is not necessarily the same as the eGFR. So I'd encourage you to use the formal calculation in those patients who are very big and overweight and very small, because sometimes you get surprises. We recommend that in CKD that the creatinine is checked on a regular basis, and certainly a reduction to the 110 dose in patients with creatinine clearance of less than 50 should be considered in patients if you're using dabigatran. But we know from the studies that there's consistent safety and efficacy profile of both doses in patients with mild to moderate renal impairment. So the other point that came out with this is really quite interesting. And we have known in the past that oral anticoagulation with warfarin can aggravate chronic kidney disease, possibly by inducing microbleeds and certainly promoting vascular calcification. And that's been a long-standing problem with warfarin. This appears from the data to be less of an issue with the NOACs. And the reason for that is it's postulated that VKAs affect this in enzyme uncarboxylated MGP, which promotes cellular proliferation and migration and leads to vascular calcification. So basically, it's thought that vitamin K antagonists inhibit this, and that allows it to allows it to promote vascular calcification, whereas the NOACs don't have the same effect on this enzyme, and there's potentially protection from vascular calcification. So that all sounds fine in theory, but it's also borne out in the clinical trial evidence. In this post hoc analysis of the RELY study, they looked at patients' renal function over time and found in the grey lines patients with warfarin, and in the light blue and darker blue lines with dabigatran, there was an attenuation of decrease in renal function over time. And if you look at it a different way, this was the mean change in eGFR over time, so it was greater with warfarin than with dabigatran. And as I said, the postulate is less vascular calcification, less microbleeds within the kidney. There was some real world data from the rivaroxaban group looking at the similar endpoints: 30% change in eGFR, doubling in creatinine, acute kidney injury and kidney failure. And you can see that basically they reduced these endpoints both in patients without and with diabetes. And on the strength of these data, the ACC and the American Heart Association and HRS said that over time, NOACs, particularly dabigatran and rivaroxaban, may be associated with lower risks of adverse renal outcomes than warfarin in patients with AF. What about the elderly? Well, again, the same set of slides, but look at the top panels. So basically 110 of dabigatran, 150, and basically patients getting older, going from top to bottom. With the 110, there was really no change in efficacy as the patients got older, and the 150 similarly. With the respect to hemorrhagic stroke, age did not significantly influence the benefits of dabigatran over warfarin. But in the patients who were older, there was an excess of bleeding in patients who received the dabigatran 150. So as patients got older, the risk of bleeding increased, as we know, and it was similar in the over 75 age with the 110, but greater with the 150. And the reason for that is that unexpectedly, patients who received the higher dose of dabigatran who are over 75 had an excess of GIT bleeding. And there's no real obvious explanation as to why that is, but it has been a fairly consistent finding. So the recommendation in most places is patients who are over 75 should receive the 110 milligram dose of warfarin rather than the 150 dabigatran rather than the 150 milligram dose. We have some meta-analyses looking at the effect of NOACs versus warfarin by age, and this is patients who are less than or greater than 75 years of age, looking at stroke and systemic embolism, major bleeding. And as you can see, this analysis from Christian Ruff shows that basically the efficacy and safety of the agents is maintained over warfarin independent of age. So really, age should not be a barrier to prescribing NOACs, and certainly they're much better than warfarin. What about in obese patients? We basically, guidelines have recommended against DOACs for anticoagulations who are at extreme body weights because there wasn't much data. And I think that's changing because there have been some analyses that suggest that this isn't so much of a concern. This is a study that was published last year looking at outcomes in DOACs versus VKAs in patients with AF across a spectrum of BMI. And you can see the warfarin in blue, DOAC or NOAC in orange. You see that across the spectrum of weight, so BMI less than 18.5, greater than 40, that the NOAC still was significantly better. Bleeding significantly less, all-cause mortality significantly less, and hemorrhagic stroke. So all the benefits of the NOACs over warfarin were maintained across a range of body weights. Just recently, there's been a meta-analysis and the result of a prospective Dresden NOAC registry looking at the effects of weight and efficacy and safety of NOACs. And I won't go into the details, but basically their highlights were increasing BMI seems to have no impact on NOAC effectiveness or safety. And the safety outcomes were comparable for obese and non-obese patients. Survival was better for obese patients versus underweight patients who received a NOAC. And there was a concept of the BMI paradox that patients who were fatter did better in patients who were thinner who had AF. So the EHRA again said low body weight may increase exposure, increase risk of bleeding, normal risk patients, and that is a legitimate concern. They've said perhaps you can measure the peak and trough levels. That's challenging, and they've noted that obesity affects the pharmacokinetics of drugs. All right, so that's sort of a run through the data from clinical trials and registries. What about saying, is there any other data that supports the use of these agents in the real world? Well, after the RELY study was published, the FDA decided they would look at real world data of how it was used in America. and basically looked at 134,000 who were anticoagulant naive, and looked who was started on either dabigatran, because that was the only one available when this was done, or warfarin. They were all recently diagnosed, all over 65, and basically there was adjustment made for confounding variables. It was done over a 2 and a bit year period, and the results were quite remarkable. This is the Medicare FDA analysis, looking at the endpoints of stroke, intracranial hemorrhage, bleeding, GI bleeding, MI mortality. The bottom panel is the RELY study, and you can see that it's superimposable data. The Medicare data, the RELY data were exactly the same in every respect, which really gives us confidence that results we saw in RELY were translated into clinical practice. We have some other studies that have been published more recently that are also very instructive. So we have RELY and reliable clinical trials, we have real-world studies, and now we've got the Gloria AF study, which is the biggest prospective study looking at outcomes in patients with AF that we've got. So it had 3 objectives: to characterize patients newly diagnosed with AF, it described patterns of antithrombotic therapy, and to collect data on the effectiveness and safety of NOACs compared with warfarin. So there were 3 phases. Phase 1 was the analysis of what the patients were like. Phase 2 went on to do that again, but also in this had some sub-analyses and specifically looking at dabigatran for the purposes of this lecture. So phase 1, to characterize patients newly diagnosed with AF and associated antithrombotic therapy, and this was before the NOACs were widely available. So most of the patients were from Asia, in particular from China, a lot from Europe, and very few from the Middle East. They had permanent, persistent, or paroxysmal AF. They were asymptomatic, asymptomatic or mildly symptomatic. And basically, when you looked at the pattern of patients who were diagnosed with AF, the majority of them had a high-risk score, so a CHADS score of greater than 2, and the majority had a low bleeding score, so high risk of stroke and low risk of bleeding, as you can see in the dark red bars. The therapies that they received were not surprising, I must admit. In Asia, majority of patients who had AF received either an antiplatelet agent or nothing. So only 20% received the VKA, which was far less than in Europe and far less than even the Middle East. So there's significant room for improvement. And so a summary of the phase 1 was that more than 3/4 of the enrolled patients were at high risk of stroke. And in Asia, most patients received antiplatelets or nothing despite the high risk. We don't recommend use of aspirin for patients with AF. And in fact, the ESC guidelines have given it a 3A indication, which means it's harmful. So we're really not recommending aspirin at all. There's no benefit and only potential harm. The Australian guidelines would support that as well. Antiplatelet therapy is not recommended for stroke prevention in AF, regardless of risk. Moderate, grade of evidence, moderate, grade strength of recommendation, strong. So the next phase of Gloria was the phase 2 study, and this looked at 15,000 patients from November 2011 to December 2014 over a global setting. And we saw again some interesting patients. So the NOACs had become available at this time, and we looked at what the prescribing patterns were compared to region. And I'll get you to concentrate primarily on the dark blue box and the orange box. In Europe, the majority of patients with AF were receiving a DOAC. In North America, similarly, but unfortunately in Asia, there still hadn't been a big penetration, and only a few patients were on NOACs. Most was still on no therapy or an antiplatelet, which was less than other parts of the world. What was even more concern is that the patients who had prior strokes, many of them were still on an antiplatelet alone or no therapies. Again, so recognizing there's significant room for improvement. The phase 3 study looked at 3,000 patients, and this was interesting because it looked at change of prescribing patterns over time. Again, many patients were in Asia, but it did show that pretty much globally that the patients with NOAC in the dark blue bars, that the use over time had increased. So in everyone, in Asia, pleasingly, there were more patients receiving it, but still a significant number on antiplatelets or nothing. Europe went up, North America went up, and Latin America stayed pretty much the same. In these analyses, we were able to look at the relative the differences in the agents that we used with respect to both efficacy and bleeding. And, So this is a data looking at basically the Gloria phase 2 data, and this is a Rely analysis saying from Europe, the European Society, saying if the patients were given the appropriate doses, looking at the outcomes. And you can see that in the real world, that the results were even more impressive than the patients that we saw in Rely. So basically, again, reinforcing the fact that the results we saw in the big clinical trials were translated to clinical practice. When we looked in patients with mild to moderate renal impairment, the effectiveness of dabigatran was maintained across the spectrum of renal function, so going from left to right, basically as the renal function declined, the benefits were maintained. There's an excess of bleeding. We expect that in patients who have renal dysfunction, but the benefits were still maintained. There was also the ability to look at the differences, compare results between patients who received different agents. And so some of the highlights, and these were propensity matched patients, so there was matches on the clinical characteristics as much as possible. So when it looked at dabigatran versus rivaroxaban, found there was a significant reduction in bleeding in the patients who received dabigatran versus rivaroxaban. And the other highlight is that when you look at dabigatran versus apixaban, there was basically similar outcomes. So really there weren't, the bleeding outcome versus rivaroxaban was similar, was less with dabigatran, and the results with apixaban were very similar. So to summarize and finish, the Gloria AF is the first global prospective study looking at comparing safety and efficacy of treatments of OACs over 3 years. In particular, with dabigatran, the bleeding was reduced by 41% compared with rivaroxaban, and the risk with apixaban were similar with dabigatran. So basically, it performs very favorably in the clinical studies and in the real world. So just to finish now, the EHRA practical guidelines, NOACs are preferred over VKAs in eligible patients. Renal function is important to acknowledge and to monitor. Co-medications and characteristics need to be considered, but much less so than warfarin. Doing an FBE at baseline is important. Estimating bleeding risk is important, but it is not a reason to deny oral anticoagulation. And again, frailty, cognitive decline, and risks of fall should not be a reason to not give patients the appropriate therapy. I haven't gone into it, but there's data that suggests you have to fall nearly 300 times a year to make the risk of falls greater than the benefits of stroke prevention. In summary, the ESC guidelines recommend ABC, which we went into before. NOACs are recommended over VKA, class 1, level A recommendation. And as I've mentioned, the safety and efficacy of dabigatran has been confirmed in the trials, but also in the real world analyses. So where does that leave us? So the requirements of the new antithrombotic agents, they really tick all the agents. The DOACs are at least as effective as warfarin. They have a predictable response, wide therapeutic window, low incidence and severity of adverse effects, an oral fixed dose, no need for routine monitoring, low potential for drug and food interactions, rapid onset and offset of action, and are cost effective. So I really agree with the current guidelines that the NOACs should be the treatment of choice compared with warfarin in patients to reduce stroke risk in AF. So I'll finish there, and we'll happy to answer any questions, and thank you for your attention. This is my hometown of Geelong in Victoria, Australia. So thank you, and enjoy the rest of the presentations.
Thank you so much, Associate Professor John Vincent Amerina.
Vâng, rất là cảm ơn.
Many thanks to the important talk and also the comprehensive presentation of Professor John Amerina. And now we would like to invite the second speaker from Germany. With the second topic.
Welcome Professor Stefan Holoza, Emeritus Professor of Cardiology, J.W. Goethe University, Germany, with the next presentation.
Hello, everybody. This is Stefan Hohenloser. I'm an electrophysiologist and cardiologist from the Goethe University in Frankfurt, Germany. I have a long interest in the treatment of patients with atrial fibrillation, and particularly in stroke prevention in this condition. Today, we're going to discuss the antithrombotic therapy in patients who have atrial fibrillation and who need to undergo PCI or ablation. And the question we want to answer at the end is, should we change our practice after new evidence stemming from randomized controlled trials? These are my disclosures. So let's start with a common problem, which is coronary artery disease and acute coronary syndrome in particular in patients with atrial fibrillation. This cartoon actually simplifies what the problem is in that condition. How do you treat, on the left-hand side, coronary thrombosis and coronary stenosis? And how do you prevent stroke prevention? And this is simplified by this transesophageal echocardiogram, where you see the left atrial appendix and a huge thrombus in that left atrial appendage. And that may give rise to strokes and peripheral embolization. So what do you do with these two conditions if they occur together? Well, patients with atrial fibrillation and a recent acute coronary syndrome, or those who need to undergo elective PCI, they require, of course, anticoagulation for stroke risk reduction associated with their rhythm disorder. They require, however, add-on single or actually dual antiplatelet therapy for reducing the risk of ischemic events after coronary interventions. And if you combine these two regimens, then of course you increase the risk of bleeding, and that is basically the problem. And back until a few years ago, the optimal combination of anticoagulation and antiplatelet therapy, which balances bleeding risk and thrombotic risk, was unknown. That's the topic of the first part of my presentation. So look at this bleeding risk of antithrombotic therapy combinations in atrial fibrillation. Here you have, because this is an elderly study, here you have warfarin monotherapy as the reference. This is aspirin monotherapy. This is clopidogrel monotherapy. Not much changes in terms of risk. However, if you add, for instance, two antiplatelet agents, you increase the risk for bleeding significantly by about 66%. If you add warfarin to aspirin, you increase the risk by about 83%. And if you add warfarin triple therapy down here, look what happens. The risk is 3.7-fold higher compared to warfarin alone. So all of these combinations carry a increased risk for bleeding events. And that gave rise for a number of trials looking at dual antithrombotic therapy in patients who underwent PCI in atrial fibrillation. This is the dabigatran study. This is the ReDual PCI study, which was published a number of years ago and paved the way, so to speak, for optimizing therapy in that condition. Have a look at the design of this multi-center randomized open label trial. It follows a PROBE design. PROBE stands for prospective randomized observational blind evaluation design. The ReDual study was a 3-arm study comparing dabigatran 150 BID with a P2Y12 inhibitor or dabigatran 110 BID with a P2Y12 inhibitor, in most instances clopidogrel, to triple therapy consisting of warfarin, P2Y12 inhibitor, and aspirin. Note that aspirin therapy was necessary only for 1 month in patients who were receiving a bare metal stent, that was the minority, or 3 months for those who received a drug-eluting stent. That's important to know. The randomization had to occur within 5 days after post-PCI. In fact, it was a little bit less at the end of the day. It was more like 3 days or so. 2,725 patients underwent randomization, and the mean duration of follow-up was, as you can see, 14 months. Key inclusion criteria, very simple. Patients with paroxysmal, persistent, or permanent atrial fibrillation, ACS, acute coronary syndrome, successfully treated by PCI and standing, stable coronary disease eligible for elective PCI was also allowed into the trial. And those were the key exclusion criteria. Probably the most relevant was severe renal impairment, creatinine clearance less than 30 ml per minute, stroke or major bleeding events within 1 month before the screening visit. This table shows you the baseline characteristics of our patient population. There's no secret in there. You can see that there was a male preponderance. 3/4 of the patients were males. You can see the age is 71 or 68 here, because randomization was according to age. So this is a typical population. The CHA2DS2-VASc score was between 3 and 4, so pretty high risk population. And you can see that drug-eluting stents were used in more than 80% of the patients. This is the main study outcome, the primary endpoint, which was time to first ISTH major or clinically relevant non-major bleeding event. On the left, you can see the comparison between warfarin triple therapy and dabigatran 110 dual therapy. Note the hazard ratio is 0.52. That means a 48% relative risk reduction in favor of dual therapy with dabigatran. On the right-hand side, you can see the same showing for dabigatran 150 milligram compared to warfarin. And you can see that even here with a higher dabigatran dose, the relative risk reduction was 28%. So quite significant outcomes of these two arms. This is basically showing the same in a little bit different way. This is a bar graph. Again, dabigatran 110 versus warfarin triple therapy. You can see the absolute risk reduction is 11.5%. That's huge for a coronary intervention. And for dabigatran 150 BID, the absolute risk reduction is 5.5%, and the relative risk reduction you have already seen. If you ask then the question, how many patients do I need to treat to spare one major bleeding or one clinically relevant non-major bleeding? This is the number needed to treat analysis in this particular trial. Note that you need to treat only 6 patients with dabigatran 110 dual therapy compared to warfarin triple therapy to avoid 1 severe bleeding event. Only 6 patients need to be treated. And for the dabigatran 150 milligram dual therapy, you need to treat only 9 patients. So very low numbers needed to treat to get benefit from this dual therapy with dabigatran 110 or 150 milligram BID. This is also an important fact. This is the rate of intracranial hemorrhage. And you can see here a relative risk reduction of 70% for the lower dabigatran dose and of almost more than 80% for dabigatran 150. So both are comparable, of course. And this is what is common to all NOACs, that they reduce the risk for intracranial hemorrhage significantly. We have shown this already in the large outcome study, the RELY trial, and you can see it again here in this other prospective study, the REDUAL study. This is the other side of the coin, if I may say so. This is time to death or thromboembolic event or unplanned revascularization. So this is, if you want not the safety, there was the bleeding events. This is efficacy. And you should know that REDUAL was not powered to look at this. So what we did for that purpose is we combined the dabigatran dosages, the 110 and 150, and compared that to warfarin triple therapy. And you can see it from the bar graph on the left-hand side and from the Kaplan-Meier incidence curves on the right-hand side that there's really no sign of harm. The efficacy seems to be comparable between warfarin triple therapy and dabigatran dual therapy. For reasons of time, I cannot go into all the sub-studies. They are mentioned here. So if you have a particular question, for instance, what was the effect of substituting clopidogrel with ticagrelor? There's a paper in the literature looking at this. Or the stent type, that is bare metal versus drug-eluting stent, renal impairment, time in therapeutic range in the warfarin arm, and so forth and so forth. There are lots of secondary analysis. And if you have particular questions, please consult these publications. They will help you to show this in more detail. Now, what has changed in terms of guidelines? What did the guideline writers take from the REDUAL trial and from the other? There are 3 other randomized trials with the other NOACs in patients with atrial fibrillation undergoing PCI. This is the latest edition of the atrial fibrillation guidelines published in the year 2020. Now, if you look at this part of the figure here, this is acute coronary syndrome treated with PCI. What you give long-term, of course, is anticoagulation, because the risk of stroke is not going away. So this is lifelong therapy in patients with atrial fibrillation. What you can see is that in ACS treated with PCI, the guideline writers recommended P2Y12 dual therapy with NOACs, obviously, for no more than 1 year. In fact, in many instances, you can reduce this to 6 months. And aspirin, as you can see here, is fading away. So the maximum, what is recommended in the guidelines, is about 1 week of therapy. If you have medically treated ACS, this is data from the Augustus trial with apixaban, you have only dual therapy and aspirin is out from the beginning on. This is chronic coronary syndrome. Again, there is a particular note that you need to long-term treat patients with NOACs. You can reduce the time for P2Y12 even more to perhaps 3 months. And aspirin is only for the time in the hospital. And this is another guideline. This is the latest edition of the guidelines for management of non-STEMI myocardial infarction. And it's good to see that these guideline writers actually came to identical conclusions. The default strategy after PCI for non-STEMI acute coronary syndrome in AF patients is this one: triple therapy just for a few days with aspirin. You can see here it's maximum 1 week, and then you change to double therapy with a NOAC and a single antiplatelet agent. And no longer than 12 months, if the patient, of course, is stable, you give the single antiplatelet, and then you go along only with the NOAC for the rest of the life of this patient. Double therapy here in patients with high bleeding risk reduced to 6 months, otherwise it's the same. And in patients with a particularly high ischemic risk, you may expand the time period for triple therapy to a month, but again, even in this high risk population, no longer than a month. This is what the guidelines actually tell us about the problem of PCI, acute coronary syndrome, and atrial fibrillation. So the take-home message is there's a substantial risk of major bleeding in atrial fibrillation patients undergoing coronary intervention. This risk can be reduced by the use of NOACs quite significantly. Redual, as well as the other trials, have shown that double therapy utilizing a NOAC and a P2Y12 inhibitor is superior in terms of safety to triple therapy with aspirin. But personalized antithrombotic therapy in atrial fibrillation patients is warranted after coronary interventions. In AF patients with stable coronary disease, monotherapy with a NOAC is the preferred treatment modality. All right, this was what I had to say for coronary interventions. Let's go now to look at the situation in patients who are undergoing ablation of atrial fibrillation, another very important topic. What can we say about the background of this? Well, it's quite clear that catheter ablation of atrial fibrillation is the most common ablation procedure performed today in major medical centers throughout the world. Thromboembolic and bleeding events, including cardiac tamponade, are some of the most feared complications of this procedure of atrial fibrillation ablation. Prior studies have shown that performance of ablation on uninterrupted anticoagulation with a VKA helps to minimize the risk of these complications. I will show you that in a minute. This approach, however, is cumbersome, as nowadays most AF patients are not receiving a VKA, but they receive a NOAC, a non-vitamin K oral anticoagulant, prior to AF ablation. Dabigatran etexylate has established efficacy. I refer you to the RELY trial, to the sub-studies of RELY, to Redual, which we have discussed, and safety for stroke prevention in patients with atrial fibrillation. But a dedicated study in patients undergoing atrial fibrillation is warranted and was long time missing. This is what I said. This is the background of AF ablation and handling of anticoagulation. This was the first study, the COMPARE study, which looked at uninterrupted versus interrupted warfarin in patients undergoing catheter ablation. You can see here 1,600 patients, 800 patients with warfarin discontinuation, 800 patients with continuous warfarin therapy. And what you can see in this bar graph and in the table here is that major bleedings occurred less often with uninterrupted warfarin, 3 versus 8, and particularly minor bleedings were less commonly encountered, 33 in uninterrupted and 174 in interrupted warfarin therapy. So this gave rise to the hypothesis that you may actually do even better if you treat patients uninterruptedly with a NOAC. This was studied in ReCircuit, the pivotal dabigatran ablation study. The objective of that trial was to investigate both safety and efficacy of uninterrupted dabigatran versus warfarin for peri-procedural anticoagulation in patients undergoing catheter ablation of atrial fibrillation. This is a 700-patient study international in 11 countries conducted, and a blinded adjudication committee assessed the data after the end of the day. Have a look at the study design of this circuit. Patients scheduled for ablation with paroxysmal or persistent non-valvular atrial fibrillation were looked for and were randomized. They were randomized and then they were treated for 4 to 8 weeks to ensure that the dabigatran patients, but more importantly, the warfarin patients, were in a stable, steady state of anticoagulation. At this point, all patients underwent transesophageal echocardiography and then went on to receive pulmonary vein isolation or whatever method of catheter ablation was used in this particular patient. The following 8 weeks, that is from the start of the ablation to the end of the follow-up period at 8 weeks, we looked for the primary endpoint. And again, the primary endpoint was adjudicated ISDH major bleeding from the or major bleeding assessed between venous access and 8 weeks, as I said. Secondary endpoints, you can see it here, thromboembolic events in the same period of time. Please note that in the ReCircuit trial, we used dabigatran 150 BID versus warfarin in all patients. So there was no 110 milligram BID arm in that particular study. This is a diagram showing the patient disposition. Nothing, no secret here. Dabigatran 340 patients, warfarin 400 patients, and this is 317 and 308 actually underwent ablation and were followed for major bleeding events. Again, this is a baseline characteristics of the patients. This is a typical ablation population. You can see that the patients were much younger than in the ReDual study or in the RELY study. 60 years on average. This is predominance of paroxysmal atrial fibrillation, reflecting the selection of candidates for catheter ablation here. The CHEST-VAS score was 2, and these were the concomitant conditions. Please note that the patients assigned to receive warfarin were very well treated. The time in therapeutic range was 66%, which is very, very good. This is the primary outcome of the ReCircuit study, the primary endpoint, major bleeds. This is dabigatran. Actually, only 5 patients had a major bleed, whereas in the warfarin arm, 22 patients had a bleed, which was of concern. So that is an absolute risk difference of 5% or relative risk reduction of 77%. So a huge significant effect with a reduction of major bleeds in patients assigned to dabigatran was noted. Here you can see in this table that the INR of patients in the warfarin group with or without major bleeding events was comparable. So it was not that patients with a bleed were receiving too much warfarin. The INR he was here 2.4 and it was 2.3 in those warfarin patients who did not show a major bleeding event. The ACT during the ablation procedure was also comparable in all 4 groups. In dabigatran, With a major bleeding event, it was 374. Without, it was 329 seconds. And in the warfarin arm, if anything, it was lower in patients with a major bleed compared to patients without a major bleed. So this was not the explanation for the observed benefit of dabigatran. This is the same showing as in the bar graph, again, Kaplan-Meier incidence curve. You can see that all these bleeding events, as you would expect, were front-loaded because they occurred early after the procedure. This is important information, I believe. This is the type and the sites of bleeding events. The most significant difference between dabigatran and warfarin occurred with respect to pericardial tamponade. There was only one such case in the dabigatran group, but there were 6 cases in the warfarin group. Pericardial effusion, 1 versus 0. Groin bleeds, comparable, but groin hematoma again, none in the dabigatran arm, but 8 in the warfarin arm. All the rest was not significant except those hematoma or complications who required medical action. There were far fewer in the dabigatran arm than in the warfarin arm. So what did the guideline writers again take from the RECIRCUIT trial and from the other trials on anticoagulation in during the situation of catheter ablation? Well, they wrote that in AF patients with stroke risk factors not taking OAC before ablation, pre-procedural management of stroke risk includes initiation of anticoagulation. And then you have to anticoagulate the patient. That's a class 1 recommendation, as you can see. And then you have to anticoagulate the patient for at least 3 weeks, or you use transesophageal echocardiography. That's a 2A. For patients who have been therapeutically anticoagulated with either warfarin or dabigatran or one of the other NOACs, performance of the ablation procedure should be carried out without interruption of oral anticoagulation, a class 1 level of evidence A indication. After, and this is also important, catheter ablation, it is recommended that systemic anticoagulation with warfarin or NOAC is continued for at least 2 months post the ablation procedure. And long-term continuation of anticoagulation beyond the 2 months time period is based on the patient's stroke risk profile and not on the apparent success or failure of the ablation procedure. That is, in my opinion, a very, very important consideration, and this is why this has a class 1 recommendation. So what is the summary of RECIRCUIT? Performance of atrial fibrillation ablation on uninterrupted dabigatran showed a significant lower rate of major bleeding compared with performance of ablation on uninterrupted warfarin. Adjudicated major bleeds occurred in 5 dabigatran-treated patients as compared to 22 warfarin-treated patients. And I have shown you the risk reduction both in terms of absolute 5.3 and relative risk reduction 77%. There was no thromboembolic events in either group and 1 TIA only in a patient on warfarin. The rates of minor bleeding events were similar in the 2 groups, as you would expect, and there were no deaths. So the conclusion is that the results of RECIRCUIT demonstrate that performance of atrial fibrillation ablation on uninterrupted dabigatran is better than anticoagulation strategy as compared with the performance of AF ablation on uninterrupted warfarin. The availability of the specific reversal agent idarucizumab, while not needed in any patient in RECIRCUIT, further motivates the adoption of uninterrupted dabigatran as the preferred anticoagulation strategy in patients undergoing AF ablation. And for this last point, let me present to you a representative case example, because I think it's important that you see what you can do today with dabigatran and its specific reversal agent. This patient was a 74-year-old male, and he had risk factors such as diabetes, arterial hypertension, coronary disease with a STEMI a number of years ago, with successful LAD standing, normal pump function, no history of bleeding events. He developed paroxysmal atrial fibrillation for the last 4 years, and the frequency of the attacks and tachycardia increased over time, as it's often the case. So the patient was actually scheduled for planned AF ablation after he had again returned to the emergency room with another attack of symptomatic atrial fibrillation. This was at the time his medication. Again, no secret. He had a pretty high CHA2DS2-VASc score of 4, and the emergency doctor called for an electrophysiologist, and the decision was taken to perform atrial fibrillation ablation. The patient was therefore admitted for pulmonary vein isolation. Dabigatran was, according to the recircuit study, continued without interruption. The patient actually took his morning pill at 7:30, and the ablation was performed between 10:30 and 12:30, which would be the peak concentration of dabigatran. And he was ablated, usually conventional radiofrequency technique. There was everything fine at the post-op echocardiography, and the patient was submitted for telemetric EKG monitoring for 24 hours. At 20:00 in the evening, the patient took his evening pill of dabigatran. At 3 o'clock in the night, a complication occurred. The patient complained of chest discomfort. His heart rate had increased from 72 to 98 beats per minute. Remember that the patient was on a beta blocker, which is why the heart rate did not increase further. That is important to note. And the patient was transferred to the IMC. An echo showed significant pericardial effusion and filling pressures of the right atrium. Unfortunately, the echo is not moving, but I will show it to you. And you see, this is a long axis. This is a 4-chamber view. You can see the large pericardial effusion here and behind the heart, particularly here. And you can see that the right ventricle is already compromised. It's compressed from the outside. And you can see again here that the pericardial effusion went around the apex of the heart and was at the back of the heart as shown in the other axis. So no question, this was swinging heart, significant pericardial infusion with beginning hemodynamic compromise. Now, the last dabigatran intake was 7 hours prior to echo, and the decision was taken to puncture the pericardial effusion because of this hemodynamic impairment. The doctor had the antidote at his hand and therefore decided to administer 2 times 2.5 milligram idarucizumab intravenously. 5 minutes later, the pericardial effusion was punctured by the cardiologist on duty. Almost 400 ml bloody pericardial infusion was drained, and the pigtail catheter was left in the pericardial sac. Another 80 milliliter was evacuated at noon, and then the catheter was removed. And note that dabigatran was paused for only 48 hours. Treatment was continued thereafter, and the further course of this patient was uneventful. At follow-up, he was still in sinus rhythm, continuing with dabigatran 150 BID. Remember that dabigatran is not available at 110 BID in the United States. So this is the only dose available in the United States. I think this is a very instructive case example of a patient who benefited from the availability of a specific reversal agent for dabigatran. And together, this is a good combination. You have dabigatran as a very effective stroke preventive therapy in various conditions and various circumstances. And you have the idarosizumab as a specific reversal agent should something happen, although this is this is a very rare occasion that you need it. It's good to have it. And therefore, I encourage you to get familiar with the use of this specific reversal agent. So this is what I wanted to tell you, and I thank you very much for your attention, and we can discuss questions if there are some. Thank you.
Rất là cảm ơn.
Many thanks to the interesting presentation of Professor Holloser. The question and the Q&A would be dealt with later. And now I would like to invite Dr. Nguyễn Tuấn Hải to talk about important topic today. Dr. Hải, please.
And been welcoming on stage Master Dr. Nguyễn Tuấn Hải, Head of Department C6 of Vietnam Heart Institute, Lecturer of Cardiology at Hanoi Medical University, with the last presentation. Please.
Ladies and gentlemen, Professor Phạm Minh Hùng, Professor John Amarina, Professor Stephen Holloser, it is my great pleasure to be here today regarding the 10-year journey of dabigatran in Vietnam. And recently, this is a presentation that I presented at the end of 2011, about 10 years ago, at the program of Medical University of Harvard and our university, talking about NOAC for non-valvular AF patients. At that time, we talked about NOAC. At that time, no NOAC in Vietnam, but time flies. NOAC are already here, not only listening and sharing clinical experience in using NOAC in today dabigatran, but also talking about the specific reversal agent antidote that can change patient outcome. We know that vitamin K antagonist has got a long time. At first, it is just something to kill the mice, but it has reduced 64%. And we have a try to optimize the therapy. We know that vitamin K has some things that are eventful, especially hemorrhage and bleeding. This is a summary in Canada. 3.8% of bleeding over the course of 5 years. 8.7% admitted hospital because of bleeding. Nearly 20% have mortality 50 years later. The first few years of 21st century, we see the NOAC, and then they switch the name to DOAC, or non-vitamin K anticoagulant. They have overcome quite a few top challenges of vitamin K antagonists, which has been persuaded by different clinical trials. For thromboembolic patients, it has shown the safety and efficacy. For example, dabigatran 150 mg versus warfarin, reducing 24% and 74% of hemorrhagic stroke. Dabigatran 110, equivalent to warfarin, but 64% of hemorrhagic stroke. So both of those doses has shown the safety and efficacy in real-life trial. NOAC is comparable to warfarin, but much safer to VKA. Somehow, in clinical practice, we have to pay attention, we have to strike the balance between bleeding risk and thromboembolic risk. Many situations can happen. They may need emergency surgery. They have bleeding. They have events. They need urgent procedures. In those cases, what do we need to do? From real-life, 2% need emergency surgical operation, and 1 in 5 elderly people may fall every year, and fall may lead to 60% of brain injury. For NOAC, they reduce the risk of bleeding, but it doesn't come down to zero compared to warfarin in real life. A little bit more than 3%. Dabigatran 150 mg has bleeding events. 110 mg, 2.7% has bleeding events. For Rocket AF, rivaroxaban 3.6%. So bleeding events must be paid attention to, and we can see it in clinical practice. When we use an anticoagulant, and if they are bleeding or hemorrhage, anticoagulant does not cause bleeding, but it would worsen the bleeding. Any emergency or urgency, life-threatening situation, we need to reverse its effect. So how can we reverse that effect according to EHRA? I would not go into detail. Non-elective surgery, immediate, urgent, or fast. We need to check the coagulation function. These are different procedures. You don't have to remember all of them. You can take this as a reference with the same procedures. But you should approach it in an individualized or personalized manner. The recommendation also talk about discontinuation or stopping NOAC before procedures, and the time after that. Discontinuation And when do we need to evaluate coagulation status to know about the efficacy of NOAC? Routine basis? No. Unnecessary. It is indicated when patient has major bleeding events, life-threatening. We need to reverse the anticoagulant status quickly, or suspected poisoning or overdose. The peak concentration is about 2 or 3 hours after administration, and the trough level. We do not talk about quantitative analysis for the dabigatran. Here are some of the tests which is related to free dabigatran: APTT, bertrobin time. It is available. Most of the time we would use APTT. Regarding the clinical rationale, it is related to the decision when to use a reversal agent of dabigatran or other NOAC. For example, we can do APTT and PT. If patient is on dabigatran, APTT is normal. It means that the drug has no more efficacy, so you don't have to use specific reversal agent. If APTT is prolonged or bertrobin time is prolonged, it means that the drug is there in the system. So you have to combine with the clinical features to use a specific reversal agent. You need to check, because some patients may have systemic lupus erythematosus. It may affect this time. In order to deal with the emergency situation, we need the cooperation of the multidisciplinary team, cardiology, emergency, doctors. When patients need to do procedures, they would indicate that when to use an antidote or specific reversal agent. And hematology, the turnaround time should be short. Sometimes if you need APTT immediately, but 2 hours later it is available, then it is too late. And it is too late for APTT can change after 2 hours. One so need strict cooperation between different levels of healthcare system. Reversal agent is not available at all different levels. Therefore, in emergency, you should connect the strategy to deal with bleeding. For moderate bleeding, activated charcoal after 2 hours, specific reversal agent. For major or life-threatening bleeding, specific agent, idarucizumab. Emergency or urgency procedures, uncontrolled bleeding. At the same time, you deliver specific reversal agent, and also don't forget the other methods. Let's take a look at this historical milestone. Warfarin, VKA, and then its antidote, and then BCC, bertrobin complex concentrate. In 2015, 2016, marking the two clinical announcements with idarucizumab and adacenet for vitamin K. Efficacy has lower onset. Therefore, it is difficult to reverse the whole process quickly. BCC is not available at all levels of the healthcare system. In 2015, Poland. The initial result on 90 patients using idarucizumab before dabigatran is still in the phase 3 clinical trial. Researchers from Boehringer have thought about how to create idarucizumab specific agent. In 2015, reversal effect is very fast. The next study using adacenet alpha for factor 10A inhibitors reported 1 year later. Adacenet alpha is a recombinant protein. Therefore, it may act on other like apixaban, rivaroxaban, and low molecular weight heparin can also be used. However, it needs time to be effective. It needs to be infused intravenously over the course of 2 hours. This is the biggest clinical trial annexed for 362 cases using apixaban and rivaroxaban in reverse with 12 hours after infusion. Clinical efficacy 82%, thrombus 10%. There's no report on the data of patients who need urgency procedures or surgery. Therefore, in 2018, FDA has approved. However, it is restricted in people with life-threatening bleeding. The use of adacenet alpha is quite complicated. We have to use a bolus dose and then infusion over the course of 2 hours, and very costly. Idarucizumab is a monoclonal antibodies, has a higher affinity to thrombin 350 times. So it combined with both dabigatran free and dabigatran, which is already bound, intravenously, effective within minutes. These are the advantages of idarucizumab to neutralize dabigatran. And there's no effect on other anticoagulant like heparin. You can restart the heparin at any time. The clinical trial reverse AD is a clinical trial, phase 3, multicenter, open label, and single arm. Group A, major bleeding, uncontrollable. Group B, urgency procedure. The major outcome: maximum neutralization within 4 hours through dilution, thrombin time, and ECT. 12 hours, 24 hours, 30 hours, or 30 days. The result is that among the group which has uncontrollable bleeding, GI bleeding, or intracranial bleeding, Group B, abdominal surgery, orthopedic, bone fractures, cardiovascular surgery. The result shows that in 2 groups, reversals of the dilution, thrombin time is very fast. 98%. Idarucizumab using 5 grams, one after another. And helpfully maintain the dabigatran low over 24 hours APTT reduction quite significantly. And these are the factors to help us control bleeding status and initiate the surgery in case we want to do it urgently. After 24 hours, if patient is indicated for anticoagulant, dabigatran may be reused. It shows that there's no residual effect of idarucizumab. Therefore, rebound effect is not there. The result shows that immediate reversal agent of dabigatran happens in most patients. And no matter what test you do, you don't have to do ECT or PTT, and you don't have to import modern machine to measure dabigatran in the blood. This is reverse AD. Extracranial bleeding, 2.5 hours. For group B, within 2 hours, then you can start the surgery. After 24 hours, dabigatran people who has a thrombus, then you can use antifibrinolytic agents after you have neutralized the effect of dabigatran. Revascularization is a goal. The brain is gold. This has been confirmed. And the SNAT alpha only indicated for life threatening. It is not indicated for the urgency procedures. Dosing administration of SNAT alpha is more complicated, more time consuming. Idarucizumab, in terms of the cost, idarucizumab is just about 1/4 of SNAT alpha. Therefore, regarding the number of cases, adalimumab, more than 10,000 medical facilities have seen that, but for androstenedione alpha, just 600. So the era of anticoagulant for non-valvular AF or thromboembolic has gone to third phase 3.0. We have an effective weapon in our hand. After reverse AD, there's another program, Revacto. This is a global program from hospital pharmacy of distribution of idarucizumab. These patients receive idarucizumab. They're not enrolled in clinical trial. Idarucizumab. They have received idarucizumab quite appropriately, and the result is consistent with the clinical trial. A cohort study in Holland for people who use adalimumab. Among 88 cases, 28% using adalimumab, but not well indicated. Or they can still use adalimumab. And that is something that you need to pay attention to when you use a reversal agent. However, in this cohort study, the result is quite consistent. A quite famous study in Germany. It is like reverse AD. And the last report on 120 patients, 80 cases with thromboembolic events, ischemic stroke. All of them receive idarucizumab. For the ischemic stroke, complete rehearsal, that is a NIS score. After receiving idarucizumab, it has improved 7 points. There's no bleeding events observed for those with hemorrhagic stroke. The volume of the hematoma is stabilized. And the NIS has improved 4 points. The ranking between 0 and 3, 63%. So we can see that the role of idarucizumab is quite important. An observational study in Spain. "22 patients has an urgency procedure, and 7 cases and the effect is quite evident among the elderly. The female cases, 81.8% of those who use dabigatran. Some of the reports from Japan, Taiwan, and Korea. The number of patients is 262 cases. 30 of them indicated for idarucizumab with the reverse So of APTT coming up to 100. Group A, the bleeding group, median time to stopping bleeding, the Japanese results confirm the efficacy and effectiveness and safety of adagrasuzumab for patients in clinical trial. Another study, adagrasuzumab 1000 and SNF 936, bleeding efficacy 78%. The group receiving adagrasuzumab alpha, the rate of thromboembolic events is the highest. Here is some other database regarding the cost. The cost when they use adagrasuzumab is lower than in the other group. Both American College, ACC and ESC, have emphasized the use of specific reversal antidote. This is the algorithm for you to choose. For example, how and when to use dabigatran, when to go for reduced dose, 110 milligram twice a day. For those who are elderly, who are using P-glycoprotein inhibitor, people who are not elderly are using verapamil, then we can go for 150 milligram per day. Age between 75 to 80. And low GFR. Of course, GFR, dabigatran, we have to follow the specific range, more than 50 milliliter per minute. This is the algorithm to control and to handle major bleeding, the type of anticoagulant, the last dose, aspirin, NSAID or antiplatelet, renal disease or renal impairment, you would have a specific antidote and other methods. And the algorithm to use adagrasuzumab. If that dose is more than 24 hours. Because after 12 hours, it has become the trough level, no longer the peak level. You don't have to repeat the test before you initiate the new treatment. If patients do not remember, or if they just take the drugs within 6 or 12 hours, we need to check whether APTT is prolonged or not, or more than 2.5. If it is, then adagrasuzumab combined with other measures. Contact emergency department or facility which has adagrasuzumab so that we can initiate the neutralization to about 2.5 milligram and then check the clinical status after 1 or 2 hours. Here's some conclusion. We see that long-term NOAC use, NOAC superior to vitamin K antagonist. Specific reversal agent are quite indispensable for people who need immediate urgency procedures or life-threatening bleeding. Either Idarucizumab provide a effective solution for us, for those who need that. And the efficacy has been, and safety has been demonstrated. Thank you. After the short video clip, we can see that dabigatran has been a trusted partner for a 10-year journey to protect the AF patient. And I'm sure that these journeys will continue and dabigatran would help a patient. And now after this, we come to the Q&A. Before we come to the Q&A, I would like to have a gentle reminder to you. If you want to raise a question, you can use your mobile phone to scan the QR code on your table, or you can put down the questions on the paper and submit it to the panelists. For those who are watching the program virtually, you can raise the questions by using Zoom function. And right after this, I would like to invite back to the stage Professor Dr. Phạm Mạnh Hùng. Dr. Nguyễn Tuấn Hải. And Professor Stefan Holloser, Professor John Vincent and Marina on the screen. Now I would like to hand over to the MC, to the chairman and the speaker. In the interest of time, we started a little bit late, so we do hope that we can have some more time for this Q&A discussion, especially the OZ professor and the German professor. Those who are here or those who are watching or virtually can send a question to us. We got some of the questions. The first question go to Dr. Hai. People with renal impairment, can they use dabigatran? Dr. Hai. Thank you for the questions. As we can see, the first speaker has told us that it is obvious that for people with mild to moderate renal impairment, NOAC in general and dabigatran in particular has been shown its efficacy, effectiveness, reducing the AKI and microbleeds and vascular calcification. eGFR more than 30, it is usable, but less than 30, it is not recommended. There is also another dose, 75 milligrams. Up to 2021, the 75 milligram dose has not been recommended by the European Society. All of the clinical trial use a cochrane. You can have that algorithm. Less than 30 milli, you have to go for VKA. From 30 to 50 milli, we use a reduced dose. Over 50, we use a 150 milligram. Some doctors are a little bit concerned. They have to use 150 milligram twice a day. They are about 70 years old. Hence, blood score is not very high. eGFR, they can use the standard dose. But some doctors just prescribe 110 milligram dose twice a day. Efficacy is equivalent to warfarin. The superior efficacy should be 150 milligrams twice a day. In my personal experience, If there are no other risk factors or there are no contraindication, I still maintain the standard dose of dabigatran. Thank you, Dr. Hai. Some of the questions are overlapping. The next question, in ESC recommendation, they talk about the low dose and reduced dose. The low dose dabigatran 110 milligram, edoxaban 30 milligram. For people who need a low dose or reduced dose, can you share with us the evidence from randomized controlled trial in people who are underweight or Asian ethnicity? Should we use a low dose NOAC like dabigatran systematically? We would like to listen to Professor John Vincent Amarina from Australia. Thank you.
Okay, thanks for that question. So I think with respect to the low dose, with the dabigatran, in the study, patients weren't randomized to a low dose. They were randomized. They were, according to renal function or age, they were just randomized to the lower or higher dose. Patients with renal dysfunction in RELY, as you just heard, did just as well as in the patients without renal dysfunction. The safety and efficacy was maintained, but we would recommend that patients who have moderate degrees of renal function receive the lower dose of dabigatran, that's the 110 milligram BD. We'd also suggest if patients are over 75 or have a high bleeding risk, that they receive the lower dose of dabigatran. With respect to rivaroxaban, the lower dose is recommended in patients who have a creatinine clearance between, at least in Australia, between 15 and 49 mils per minute. So there's a wider range of use for rivaroxaban in patients with more advanced degrees of renal dysfunction. And with apixaban, the lower dose is recommended in patients who have two of these three characteristics: that's age greater than 80, body weight less than 60, and creatinine of greater than 133 millimoles per liter. And if the patients had those characteristics, all three, two of those three, in Aristotle, they received the lower dose. Now, there weren't a lot of patients who received the lower dose of apixaban in the study, and there's many more patients received with renal dysfunction and lower dose in the ROCKET study and in the lower dose in RELY study. So you can be more reliant that there's a better patient representation in those studies. With respect to overweight, the studies that I've seen at least would say that really we don't have to dose adjust any of the doses of NOACs for weight, except in that Aristotle population. If the body weight is low and they're either over 80 or have a creatinine greater than 133, you would use the lower dose.
Thank you. There are some other questions for Professor Holloser. In REDUO PCI, 83.6% regarding non-inferiority of the dual therapy of dabigatran versus triple therapy of warfarin. And I wonder why this study is not stratified to different doses, but they have to combine both dabigatran 110 and dabigatran 150 for analysis.
Thank you for the question. It's a very good point. And the reason why we lumped together the two dabigatran dosages when we looked at efficacy, that is thromboembolic events, myocardial infarction, stent thrombosis, was simply a statistical power issue. The power was not high enough with 2,700 patients to analyze the triple therapy against two dabigatran dosages separately. This is why we lumped together the two dabigatran dosages and compared them to warfarin triple therapy.
Another question for Professor Holloser. In the recircuit clinical trial, it is conducted in modern centers in the world, but in Vietnam, we don't have that many modern centers. So when we carry out ablation procedures in some centers, does it mean that it is totally necessary to have specific reversal agent available at that center to do the ablation procedure? Is it mandatory to do so?
Well, again, this is a good point. Yes, you are right. The circuit study was carried out in experienced centers, predominantly in experienced centers. So they were familiar with the ablation procedure, with pulmonary vein isolation in particular, quite well. And I believe that this is the major point which is to be made here, that that pulmonary vein isolation should be carried out in specialized centers who are experienced with this procedure. And yes, if you do the procedure in a patient on dabigatran, uninterrupted dabigatran, as the circuit study and other studies indicate, then I would advocate to have idarucizumab at hand in those centers should something happen like pericardial tamponade. I have shown you this example of the elderly gentleman who developed pericardial tamponade. This can be life-threatening, and therefore, if you have something which is as effective as idarucizumab, you should have it at hand. That's my recommendation here.
Also would like to ask Dr. Hai for the same thing. Do you think that the Institute of Cardiology or some other centers in Vietnam, we carry out ablation procedures? Patient don't have to stop or discontinue, no, they still use it uninterrupted. So, do you think that it is mandatory to have specific reversal agent at hand? Thank you. In the recircuit, more than 600 cases with ablation procedures, one group using dabigatran and the other group using warfarin. Cardiac blue effusion is just observed in 7 cases. I do not talk about high volume ablation procedures at my centers. For the past 5 or 7 years, we haven't seen any cases of cardiac tamponade or cardiac effusion at all. So even though that the experience of the operator is experienced, for people with vitamin K antagonist, if INI is more than 3, we would not perform that procedure. So if patient is currently on NOAC or VKA, you can still use it uninterruptedly. If you don't have adalimumab in your center, it does not mean a contraindication to do ablation procedure. If you have adalimumab, then it is another level of safety and security. So we know that if we have adalimumab, it would be in an optimal and an ideal situation. So we should go for the NOAC, which has a specific reversal agent, and it is available, and also the cost is more affordable. And so we need to know which center, which is nearest to you, which has adalimumab. I would like to ask Boehringer Ingelheim Company, can you tell us about the local availability of adalimumab in Vietnam? In the north, I know that Hanoi Heart Center and McMai Hospital has adalimumab. And how about the south? Thank you for your questions. On behalf of the company, I would like to share with you the information of the hospital which has adalimumab. Until now, 12 hospitals has this in Hanoi. There are 2 hospitals, McMai Hospital and Institute of Cardiology. In Ho Chi Minh City, there are 10 hospitals with adalimumab. So in case that you have any doubt, please consult a Boehringer Ingelheim representative. Another question for Professor Amarina.
Events in patients with non-valvular atrial fibrillation. Would you like to share your experience about what is the optimal time for restarting NOACs in patients with intracranial hemorrhage and non-valvular AF? How to deal with the patient with intracranial hemorrhage who develop conduction such as myocardial infarction, ischemic stroke, and pulmonary embolisms?
Okay, thanks very much. So just before I get to that, I could just make a comment about the reversal agents. We've had experience in Australia with idrisiximab, and Australia is a country of maybe 25 million people, and then through the whole country, about 1 dose is used per day. The majority of that, or 2/3 of the doses, are used to allow urgent surgery to be done, and about 1/3 are used for bleeding. So it's an agent we've had a lot of success with, and it really does work very effectively in those contexts. Things may improve in the future in that there's a new agent that's being developed called ciperantang, which is by reputation supposed to reverse everything. Clexane, fondaparinux, all the NOACs, warfarin. It's in a stage of development, but it's getting there. So within the foreseeable future, you might find this agent becoming available to make it much safer to do procedures, whatever anticoagulant the patient is on. Now, with respect to the question you asked, basically it's a major problem. The risk of intracranial hemorrhage is lower with NOACs than with warfarin, but it still occurs. And the question is, how do you manage it? Well, there's some data that shows if you have an intracranial hemorrhage on dabigatran and you administer idrosiximab, the outcome is better than if you don't. So that's something you can do. But the question then becomes, what do you have for the future? How do you manage this patient who's at high risk of stroke, who's had an intracranial hemorrhage on an anticoagulant? In our practice, the optimal treatment for that patient would be to insert a left atrial appendage occlusive device, like a Watchman device or an Amplatzer device, so that you effectively exclude the left atrial appendage from the circulation and reduce the risk of bleeding. So initially, they have to have antiplatelet therapy, maybe anticoagulation. There's a lot of debate about that. But in the long term, that's probably the best option, is to do that if that procedure is available. If that's not available, then there's not a lot of literature to say when to resume it. But in the stroke world, they would say if it's a small stroke, you resume anticoagulation within 2 to 3 days. If it's a larger stroke, within a week. And if it's a medium stroke, a week. If it's a large stroke, 2 weeks. And that's the so-called Diener's rule, after this guy, Chris Diener, who I'm sure Stefan knows, is a very, really national and international expert on stroke management. So it's a really difficult situation, and you have to weigh up the risks and benefits of resuming anticoagulation in those patients. And as I say, in an ideal world, left atrial appendage occlusion is the way to go in that sort of patient population.
There's another important question. Professor Marina, can you share with us how to use NOAC in people with liver impairment, people with liver failure?
Okay, yeah, again, another very important question. There's really no hepatic dysfunction associated with any of the NOACs. The initial agent that was tested, whose name I forgot, was an Astra product, didn't make it to market because it did have significant hepatic toxicity. But the other agents, liver dysfunction is not a contraindication to using them. I suppose the only problem would be is if they've got severe liver dysfunction and your INR off any anticoagulation is elevated, you'd be more concerned about prescribing an anticoagulant. But liver dysfunction in its own right is not a contraindication to starting any of the NOACs.
In the interest of time, we have to call it a day. And for the remaining questions, I'm going to forward them to the speaker to answer you later. I would like to summarize the meeting today. Today, we talk about the dabigatran 10 years of protecting patients and confidence in therapy and with reversal agent. In today, you are sitting here at the Lotte Hotel, and those who are joining virtually, we have heard 3 important lectures from KOL. but not NOAC is the same. Not NOAC. One NOAC is the same as others. Those are the information from the real-world evidence and clinical trial demonstrating that NOAC is a direct thrombin inhibitor. It is different from other NOAC factor 10A inhibitor with a lot of advantages in elderly cases. And reversal agent giving us more confidence in treatment. We have learned about the latest recommendation in using NOAC for NVAF who has acute coronary syndrome and who need ablation procedure. The use of anticoagulant when we need to have coronary intervention procedures. NOAC once again has shown to be effective in patient protection. And the fact that we combine two drugs at the same time and after 12 months or even shorter in people with higher bleeding risk, the use of NOAC can prevent patient events. Or for those who need ablation procedures, the use of NOAC such as dabigatran with specific reversal agent give us assurance and confidence. Just in case, the last presentation, which is important, by Dr. Hai, telling us the algorithm of what to do. For example, intracranial hemorrhage or major GI bleeding, or those who need the urgent procedures, then specific reversal agent, especially for dabigatran. Pass-by or idarucizumab can help us to treat patients safely, just in case they need procedures or bleeding. And today is a very fascinating event with all the questions. We have heard the clinical experience sharing from world leading doctors. We do hope that today we have learned the practical experience. We also know, I also would like to thank Professor John Marina, Research Hornloser, Dr. Hai, who are the speaker for today's event, who will share with us the latest update. We also would like to thank the doctors who are here on site and those who are joining virtually. Gratitude also go to Boehringer Ingelheim with this conference, both in scale and I also would like to remind you that on the 7th and the 8th of October, the 18th National Cardiology Conference would happen in Quảng Ninh. Would like to welcome all of you to be there. There are quite a few speakers at home and abroad. And there would be the announcement of the 10 recommendation from cardiac intervention, hypertension, and rhythm society, and so on. And please be there. Thank you. Thank you. Thank you. Please be on stage. And right after this, I would like to invite Boehringer Ingelheim Vietnam to give the flower bouquet of flowers to our speakers.
We'd like to share our appreciation to Professor Stefan Holazer and Associate Professor John Vincent Marina. Thank you so much for joining us today. Sức mạnh